Understanding risk and vulnerability are obviously critical to mitigating threats to the security on all levels of our society. And the theme of this afternoon's session is reducing vulnerability. We will hear from 3 experts who will share real solutions for minimizing cyber threats, addressing food insecurity, and reducing biological threats. Our first speaker is Dr. Jade Lee. She's a local. She's an associate professor of internal medicine and Dedman Family Scholar in clinical care at the UT Southwestern Medical Center. She's going to speak with us today about the risks and vulnerabilities of infectious diseases and the work being done to limit the impact of threats like Zika and Ebola. Dr. Lee?
Thank you. So thank you very much for having me here today. What I'll be talking about is poverty and the risks of biothreats. So as a 21-year-old Peace Corps volunteer in Boué, Gabon in Central Africa, I watched personally Ebola wipe out villages. I witnessed how poverty contributed to its emergence and its spread. In that outbreak, a local hunter found a dead monkey in the forest and brought it home for food. In that part of the world, there really are no supermarkets, and even if there were, most people can't afford to buy the food, so they forage and hunt for it. The family members who helped him prepare that bushmeat became infected. He went to see a local village doctor, witch doctor, because the nearest medical center was a few hours away if you were lucky enough to hitch a ride. He died, and all his immediate family members also died. That local witch doctor also contracted Ebola and passed it on to multiple other villagers from the nearby villages who had come to see him for help, thus escalating a chain of events leading to about 30 deaths during that outbreak. It took a coordinated effort by the public local health department as well as the military to stop that outbreak. They had to quarantine the patients, they had to isolate and survey those close contacts, and they had to stop the local burial practice, which basically consisted of washing the dead bodies by hand. Oh, thank you. I witnessed this in 1996, and back then I never imagined that Ebola would one day arrive in Dallas, Texas, 18 years later. Since its discovery in 1947, Ebola outbreaks have arisen sporadically in remote villages of Africa, spread by poverty. For example, in Kikwit, Zaire, the nurses would use the same needle to inject vitamins into patients going from one to the next, spreading Ebola that way. Family members would participate in burial rituals, washing the bodies of their beloved victims, basically spreading the virus. Deforestation led to hunters coming into contact with infected bushmeat more often, thereby spreading the virus. But these outbreaks were contained in the remote villages in Africa, so we didn't pay attention. Fast forward to 2014, with the advent of globalization, ease of travel between villages, cities, and countries, the Ebola outbreak spiraled out of control, infecting over 28,000 people in 10 countries, leading to over 11,000 deaths. Poverty again contributed, but this time on a much grander scale. Deforestation leading to increased contact between bushmeat and humans led to spread of the virus. Urbanization leading to overcrowding, increased person-to-person contact, and lack of water, sewage systems, as well as overwhelmed health departments contributed to the spread of this virus. The virus, which had been circulating in the remote African rainforest for decades, now chanced upon a completely vulnerable population, taking advantage of the fact that people could travel more rapidly between villages and between towns to facilitate its spread. Ebola can hide in the body for days before the infected person shows symptoms. Therefore, by the time it manifests, it may be too late and that person has traveled and thus infected others. Thus, Ebola arrived in Dallas in 2014 in a Liberian traveler. Unfortunately, 2 nurses who cared for this patient became infected, but they survived, and the outbreak did not manifest in the community due to the vigilance of the local public health department and the valiant care of the medical providers at that local hospital. However, the country was up in arms, and I remember people delaying or canceling their travel to Dallas for fear of Ebola. I remember parents pulling their children out of the schools in the suburbs due to fear of Ebola, afraid of the local outbreak that actually never took place here. It took a coordinated strategy between the World Health Organization, the Centers for Disease Control, Doctors Without Borders, and numerous domestic and international agencies to control the Ebola outbreak in 2016, this year, 2 years after it originated. But this is not the only biologic threat that we need to know about. So before 2013, had any of you heard of chikungunya virus? I doubt not. Essentially, this is a virus that originated in Africa, slowly spread through the Indian Ocean, through Southeast Asia, and then Europe. But it wasn't until 2013 when it hit the Caribbean islands and Latin America, leaving over 1 million people with a debilitating arthritis, did we pay attention. For chikungunya in an African language means that which bends because of the debilitating arthritis that it causes. And unlike Ebola, which relies on person-to-person spread, chikungunya is spread through the bite of a mosquito, which facilitates its transmission. Before 2015, had any of y'all heard of Zika virus? Probably not. Again, this is an old virus that originated in Africa, leading to sporadic outbreaks in local villages and towns. This virus also traveled through to the Indian Ocean in 2003, later Brazil in 2014. But really, it was the devastating outbreak of over 1,000 babies with microcephaly in Brazil in 2014 when Zika came to our attention. And now we're just watching it spread through South and Central America and the Caribbean islands, and we've got over 4,000 imported cases in the United States to date. Because of Zika, travelers are really thinking about altering their vacation plans, and young families who are young couples wanting to start families are having to think about where they go for vacation or their honeymoon, unless they want to practice abstinence or barrier contraception for up to 6 months after travel to a Zika endemic area. This is the first sexually transmitted virus that is spread through the bite of a mosquito. The tourism industries in the Caribbean and Latin America have been hit pretty hard. And if y'all remember, the Rio Olympics attendance dropped because of concerns about Zika virus. And raise your hands, have you or any family members or friends altered their plans for travel because of Zika? I get this question I get this question almost every week. Oh, my daughter-in-law or my granddaughter or my daughter wants to go to Miami. Is it safe for her? And I have to answer these questions almost every week from my patients. In the case of Zika and chikungunya, poverty also contributes to their spread, but through the mosquito. Because of deforestation, the ecological niche of the mosquito has been altered. Because of rapid urbanization and the overcrowded slums with the large piles of trash everywhere, the mosquito breeding habitat has increased. Because of climate change, the mosquito territory has gone further north and further south. And the warmer temperature is perfect for mosquito and viral replication. In fact, the Anopheles mosquito, which transmits Zika and chikungunya and dengue and malaria and many other pathogens, evolved to coexist with us, with humans. It breeds in the water containers and the crevices around our homes, not in the trees like other mosquito species do. It preferentially bites us, humans, not birds, not mammals. And so through deforestation and through rapid urbanization, we humans have created the perfect human bioweapon in the mosquito. It carries many viruses and other parasites and pathogens. It hides around where we live, and it preferentially feasts on us while transmitting infectious pathogens that can make us sick or even kill us. Fortunately, in our country, most of us live in homes that have screens on our windows and our doors. We have access to insect repellent, and we don't see large piles of trash and tires outside our doorsteps and on our lawns. However, in the United States, it is in the poor neighborhoods that are most at risk. This is where you may see houses that don't have screens on their doors or windows. You may see tires or piles of trash in the backyard collecting water to breed more mosquitoes. These may be the neighborhoods where people cannot afford to buy the insect repellent or to pay for doctor visits. These may be the areas where there's a lot of travel in the workers across the border looking for work. Or these may be the areas where there may be multiple family units living in the same cramped apartment or house. These are perfect conditions for the spread of infectious diseases and pathogens, and we should pay attention. The international health community right now is on high alert because of Zika. And it'll take a coordinated effort with a focus on reducing mosquito breeding sites, targeting the vulnerable populations through educational campaigns in order for us to prevent the spread of this virus through the southeastern part of the US, which is a huge hotspot for Zika right now. Viruses such as Ebola, Zika, and chikungunya until recently were felt to be infectious pathogens relegated to poverty, war-stricken areas of the world, with deforestation, conflict, rapid urbanization, and climate change to blame. These are old viruses discovered over half a century ago, but because they were relegated to these remote African villages, we did not pay attention. Unlike these viruses, another biologic threat that we should pay attention to is SARS, or severe acute respiratory syndrome. I'm sure y'all remember SARS from China in 2002. Unlike Ebola, SARS is not an old virus, but a new virus that emerged not in Africa, but in Asia. And imagine within 8 months of infecting a farmer in rural China, this virus basically spread across international borders and threatened the global community, leading to over 700 deaths in 37 countries. As with Ebola, poverty also contributed to its spread. Deforestation, increased human to bat contact initiated this outbreak. Rapid urbanization leading to overcrowded slums and close proximity to those wet markets where all those wildlife are sold contributed to its spread. Ease of global travel through air and land transportation contributed to its spread. Lack of public health communication and failure of infection prevention contributed to its spread. Lack of funding to pay medical bills prevented some patients from being hospitalized and cared for. That contributed to its spread. In fact, one patient escaped quarantine because he felt the government wasn't going to take care of him and pay for his medical bills. And that contributed to its spread. Although the outbreak took place in November 2002 and reports of a flu outbreak in China were circulating on the internet and all through mobile text messages, it wasn't until 3 months later when an American traveler in China developed pneumonia and died in Vietnam where his plane had stopped, infecting numerous others. That's when we paid attention, and the outbreak strained local health departments and set off a panic. Schools, restaurants, and businesses closed, and the tourism industry in Hong Kong and China suffered. It took coordinated effort amongst the global medical and public health community, as well as intense resources to quarantine over 10,000 people to contain that outbreak. Since SARS and avian flu, along with the emergence of other pathogens such as rabies in the setting of deforestation, rapid urbanization, livestock production, and climate change, the Chinese government created the One Health strategy in order to lead to cross-sector collaboration and communication amongst the animal, human, and environmental health services in order to facilitate surveillance, reporting, and communication. The government invested heavily in public health infrastructure. They built new labs, they upgraded their surveillance system, and they also hired more public health personnel. However, we have yet to hear about any improvements in terms of taking care of poverty, reducing poverty, and providing medical care for those rural farmers and urban dwellers. So what lessons have we learned from these outbreaks? First, poverty is at the root of the emergence of these biologic pathogens. Poverty leads to deforestation and increased contact between these pathogens, these biologic pathogens and humans. Poverty leads to deforestation and climate changes with the expansion of vectors such as mosquitoes, which facilitate the spread of these biologic threats. Poverty leads to rapid urbanization and the development of urban slums and overcrowding, which overwhelm water sanitation services as well as local public health infrastructure. Poverty leads to increased travel in the search for jobs and appropriate health care, allowing biologic threats from remote villages to penetrate large cities and cross the globe. These biologic threats are no longer restricted to Africa and Asia, as they had been in the past, and we can no longer afford to ignore them. We must pay attention. So how can we as a society reduce our vulnerability to these biologic threats? Well, we should target poverty by improving access to jobs, appropriate health care, as well as housing. We should focus on city planning to ensure safe drinking water and sanitation services, as well as ensure that our local health departments are equipped to handle these biologic threats should they arrive. We should focus on improving housing in urban areas to reduce mosquito breeding sites and control the rat populations. We should understand the rapid urbanization and deforestation in Africa and Asia and how that impacts the emergence of these biologic threats. We should further develop our infectious disease surveillance systems and ensure that we can monitor in real time the emergence and re-emergence of these biologic threats and ensure that we can rapidly communicate information to those hotspots and populations at highest risk. We should focus on an efficient international collaboration to contain these outbreaks. We should focus on vaccine development and implementation for these infectious diseases to ensure that those who are most vulnerable are protected and immune. In essence, we as a global society now, we must realize that poverty plays such a huge role in the emergence and re-emergence of these biologic threats, and that our current travel ease facilitates their spread. We can't reduce our vulnerability by building large walls or halting immigration or travel. But we can work together to improve infectious disease surveillance, and we can target these hotspots of emerging infections by working on ways to reduce poverty in those affected areas. As that 21-year-old Peace Corps volunteer in Central Africa, I witnessed the devastation of Ebola in those villages. I mean, I had family members of those that I was close to who died. Entire houses boarded up because everyone in there, the 8 or 9 people died. And now, 20 years later, as an infectious disease doctor, I am prepared to handle Ebola should arrive on our shores. And in fact, I'm part of the team that rules out every single Ebola person under interest at UT Southwestern. And we've ruled out 11 to date. But I just need your help in figuring out ways to prevent viruses and biologic threats such as these from arriving and from re-emerging through addressing poverty and rapid urbanization overseas. Thank you.